Samantha Underbaki, and today I'll be talking about the swimmer's technique that is used with the C and T spine. What is a swimmer's technique? The swimmer's technique is a lateral view used to visualize the C7 and T1 junction of the spine. Usually, whenever you do the lateral view of the C spine, if you cannot see C7, then usually they will make you do a swimmer's technique. That way they can visualize the junction between C7 and T1. Also, most facilities that I have rotated through, they usually make it to where anytime you do a T-spine, you do a swimmer's view also. Positioning a patient for the swimmer's technique. You will put your patient in the lateral position, whether they are standing, sitting, or laying down. Standing and laying down are the most common that I've seen, but if you have a patient that you cannot move out of the wheelchair or something like that, you can have them sitting in the wheelchair and put them up against the bucky in the lateral view. Sometimes that does become compromised whenever the wheelchair handles or anything metal can get in the way, but also at some hospitals the handles can detach. The arm closest to the IR will be elevated straight up above the head and with the arm bent and resting on the head. The arm furthest from the IR will be resting by their side. And when I say resting by their side, I mean you want your arm that is furthest from the IR to be basically pushed down. So you want to tell your patient when you're communicating with them to try to touch the ground without bending over. The IR runs parallel to the patient's C-spine, and the image is taken on suspended expiration or with the breathing technique. So you will tell your patient, take a deep breath in and let it all the way out. Try to touch the floor with that arm and beep. Also, with the breathing technique, you can just have them breathe normally, give them their directions on trying to touch the floor without bending over, and then the breathing technique comes with a longer exposure time to try to blur out the motion. Technical factors. Your central ray will be 2.5 centimeters above the jugular notch at the level of T1. And sometimes, whenever you get, well, I say sometimes, but most facilities, they automatically do the 3.5-degree cauted angle. But with research, they say you're only supposed to do the 3.5-degree cauted angle whenever the patient cannot depress their shoulder enough. But I've noticed that almost at every single facility I have been to, you automatically just go ahead and do that 3.5 or 3 to 5-degree cauted angle. Your collimation will be superior to C1 and inferior to T3. It will be anterior to the vertebral bodies and posterior to the spinous processes. That bullet explains everything that needs to be within your light field. Your SID will be at 100 centimeters. With that being converted to inches, it ends up being 42 inches. Your recommended exposure factors are 80 to 90 kVp and 120 to 150 mass. I know most of the time we use AEC, which is automatic exposure controls, but this is also good to know just in case that ever goes down. Evaluation criteria. This image is a perfect image. You could tell your central ray is at the correct position. You have clear visualization of T7 and T1. The vertebral bodies are superimposed laterally. The articular pillars and the zygophageal joints are superimposed. The vertebral disc of space should be open. This will make sure that your patient is in a clear lateral position. Also, you see that you have the anterior of the vertebral bodies and posterior of the spinous processes. Image analysis. This is a poor diagnostic image. It does not show the junction of C7 and T1. A good rule of thumb would be whenever you're trying to look at an image like this and you want to make sure that the central ray was on point, which it was not in this image, you can make a straight cross in the middle of each longitudinal and horizontal ways and make sure that they put their central ray in the right spot. You could clearly tell that they did not. It seems as if they put their central ray at the level a little bit maybe below T7, and that is not correct. It's supposed to be, 2.5 centimeters above the jugular notch. This image is also overexposed. They did not use the correct technical factors. And like I said, they have an incorrect central ray and unnecessary exposed anatomy. You see in this image that we basically got a chest x-ray, and that is not correct. We do not need a chest x-ray at all. And also, another thing to notice is that the marker is within the anatomy. No, it's not within the anatomy that we are specifically trying to visualize, but it's also within the anatomy. This image was found in the library of images provided to us by the school computers. This image. This image clearly shows the junction of C7 and T1. The collimation is good, showing the spinous processes and the vertebral bodies. You have open disc space. And the only thing that I could specifically find wrong with this image was that it does not have an anatomical marker within the field of view. And of course, we know that you need one of those, whether just for good practice, for legal reasons, and to let your radiologist know exactly what side we're looking at, which side is down, because that is the side you will be marking when it comes to spinal work and chest work too. Also, you want to mark the side down. This is another image. No, there is no anatomical marker within the image. The patient is not in the correct anatomical position. You could tell that because if you look a little bit further down, and I know that it's not exactly what we are looking at when it comes to these images, when it comes to spine work, but you could tell the patient is rotated because the posterior ribs are not superimposed like they should be. So this means our patient is, I would say the patient is over rotated, but the patient could be under rotated. Also, it does not look like they have their central ray in the correct area. Again, that's another problem. Remember, you want it to be skimming the top of the shoulder. That's an easier way to say, 2.5 centimeters above the jugular notch. And you want to have that 3.5 degree cotted angle on there. C7 and T1 are not shown they are shown, but they are not clearly shown within profile. And the spinous processes are shown in this image, and also the vertebral bodies are interior of the vertebral bodies are shown in this image. But also another thing is we do not have the marker. This is the perfect image. Of course, the only thing I would say, and this is just over critiquing, is maybe try to depress that chin down a little bit. That way we can get a little bit more of the opening and the spinous processes aren't so crunched up together. But other than that, it's the perfect image. It has the correct central ray. It has amazing technical factors. The image demonstrates the junction of C7 and T1. You have open spaces between the vertebral bodies showing the patient is in the proper lateral position. The only negative that I can see about this image is the technologist did not place a marker within the field. And that seems to be very, very common. And I know that you can put one up at the computer, at the control station. You can put a marker on the image, but you also want to do that automatically because when it comes to legal fees, or I'm sorry, not legal fees, but legal situations, a marker that is placed on there by the computer will not hold up in the court. And here are some questions that would help you whenever we get further along and we go to take our registry. Question number 1 is what anatomy is in profile when completing a swimmer's technique x-ray? And the answer is C7 and T1 vertebral junction. What position is the patient in for the swimmer's technique? And the answer is the lateral position, and that is whether they are sitting, standing, or laying down, no matter what, they will still be in the lateral position. When is the lateral cervicothoracic swimmer's projection needed? Is needed when C7 is not well demonstrated on the lateral C-spine projection, and to better visualize the T1 and T3 on the lateral T-spine projection. Here are the references that I used. I did not completely know how to reference to do the APA format referencing the school image library. So I did say that I used the school image library, and then I used all the other ones, all the